We can start this session. It's a session on best bifurcation PCI tricks. You have, I am one of the chairmen, and together with Mila Kovacevic, Nigel Jepson from Australia, and the panel there is Sarita Rao from India, Farhat Fouladvand from Italy. Excuse me for the pronunciation, Hamid Reza Sanati from Iran, Meruzhan Saghatelyan from Armenia, and Vojacek from Czech Republic. So each case have, each presenter of the cases, there are 5 cases, has 14 minutes in total. So we have some discussion at the end if the presenter will have maybe 10 minutes, and for discussion 2 or 3, 4 minutes, depends on the type of presentation. So we can. I think that we can start with the first presenter is Jozica Sikic, and the title is New Tools and Leave Less Behind.
All right, so ladies and gentlemen, dear colleagues, it is my pleasure to be again here with you, and also it is my honor to open this EBC 2024. So my talk will be about some new tools and how about to leave as less as possible behind. So this is a story about a male. He is 1949 born. He came to the CCU due to STMI of inferior segment, and he had also AV block of 2nd and 3rd degrees due to benzodiazepine chemical reaction. And we transferred him immediately to the cath lab. So he had also myocardial infarction previously, and it was 2008, and at that time he received the BMS on RIM, and he suffered from hypertension, hyperlipidemia, atherosclerosis, he had a PAD, and he is unfortunately a smoker. So this is one very simple occlusion of RCA with a simple solution with 1 stent, nothing special. But what we found on the left, there is some trifurcation lesion. As you can see, there is a long lesion on the LAD and also on the ostial part. There is quite a nice stenosis of proximal part of rim, just in front of the stent. That means that is in segment lesion, because stent is just 2 millimeters from the ostium, and there is some narrowing on the ACX as well. And on that right side, you can see that there is a bifurcation lesion with diagonal branch, that there is a lot of calcification as well. And you can see that we have a dominant septal branch and subocclusion with the calcification of LAD. So this patient had low ejection fraction. It was about 35%. He had a MR moderate and a little bit bigger left ventricle. So we decided to put IVAC, not just for him, but also for our convenient, because we thought that we will feel safer and better if he had IVAC. So we implanted IVAC, and you can see here that situation what we have on the left branches. So I took a Grand Slam. It was a little bit problem with the ostial part due to calcification. Grand Slam is, the reason from Grand Slam is rota. So I made rotablation with Rota Pro 1.1025 because it's a really heavy calcification. You can see here there is some trouble in that diagonal, not the diagonal, but on the bifurcation with the diagonal branch, and also in bifurcation with the septal branch. You can see this work how is going, but finally I passed with 1.5. And after that I had this result. I lost the LAD and the septal branch as well. I think that it it was because of the dust of calcification, but also maybe I have some ruptured plaque. So I took a Wolverine cutting balloon and I cutting that stenosis, and this was the reason. So I thought, okay, it's good enough and I can treat this vessel with DCB. Then I move further and treat the LAD with scoring balloon because this calcification was not so heavy, and then I took another DCB. This is a result which is not, I think, optimal, but is acceptable, and both balloons are paclitaxel balloons, so I was counting of late lumen enlargement. So I moved further to the proximal part, and as you can see here, I treated LID, but I had, unfortunately, dissection because my idea was at the beginning to treat the LID with the DCB as well. So I treated the rim with the balloon and then with the DCB, and I checked this ACX because this narrowing on the osteum looks worse than on the previous picture, but it was still insignificant. So I implanted two DCB, one on the proximal part and one on the distal part. If you remember, there is a problem on the distal part of rim as well. So after implantation of this of LAD and left main and the pot, this was the result. This patient had a cardiorenal syndrome, and at that point I didn't use OCT, so I let him go. What's happened? Something happened. He didn't die. He felt good. I checked the presentation just a few minutes before and everything was fine. Can you go back? Yes. Static again, okay. I will show you. So what I perform is...
Sorry, the computer freeze, just we restart it
okay.
And we will be able to put the presentation. Sorry for that.
Okay. We can discuss. Yeah, of course, we can discuss so far.
Yeah, what was the idea and reason to use... maybe it's... Sorry?
So, okay.
Okay, good.
This was a rotacut, you saw it. This was a bifurcation. This was a left main and LAD. And, okay. So I just took a stent boost. And you can see here that is quite a good position of stent in left main and LAD. And it's a good expansion. But maybe you can see here. Stop. There is a loss of calcification, but it's calcification out of the stents and of the lumen. It looks like that on this picture. So I occluded the puncture place with the two prostyles. I performed DSA and I let him go. So maybe we can talk about it now, or I can maybe finish. Okay, so a few months later he came again. He had all the therapy for heart failure, and now his ejection fraction was about 45. His MR wasn't so moderate anymore, it was mild to moderate, and his left ventricle diameter was even better. So his EGFR is also going better, so I perform angio, and it looks good. And you see also this wire, and that wire is because of the OCT, so I took OCT. we spoke a lot about saline, especially my friend from Lucerne, he enjoyed saline so much. So I tried to use the saline and the contrast, and so this is the result with the saline. There is lots of blood, but it is readable. And this is a result with contrast. It's much better picture. But on the both picture, you can see that there is some problem with the stent expansion, and that was on the point of that high calcified plaque in the proximal part of LID. So I treated with balloon, and I thought the result was good. So what is the case learnings? That IVAC is good. It gives us no more than 2 liters, maybe 1.8. I think that is optimum what IVAC can give us. It needs about 70 Frenches, 17, which means that is quite robust tools, but it is cheaper, much cheaper than Impella. And it's a good, and we have some good results from the studies in high-risk patients, and also help us to feel better. I think that the DCB option is very good for DCB only treatment, but sometimes is for DCB as a hybrid option, because we will have a less stent burden, and maybe we can reduce the MACE. Last year in Warsaw, we were talking about OCT, and we said the OCT is must to do in the bifurcation lesion, so I did it. And I think also that OCT give us lots of information, and it is proud also with this case, because you saw that on the stent bust that the stent expansion was excellent, but there is also huge geographical miss. And also in the case of low EGFR, we can use heparinized saline instead of contrast to save the rains. So that's all. Thank you.
Thank you, Jozica. It's a really great presentation. A lot of tools that you showed us used in one patient. And I wanted to ask, what was the reason for IVAC? Because the patient in primary PCI, during the primary PCI, he had occluded RCA and left coronary system, which was severely diseased, and he survived this primary PCI. However, I understand, like cheap patient, low ejection fraction, and a lot of things to do in the setting of left system of the left coronary artery. That's why I probably use to be more secure during the procedure. And what was the reason? I like really to use DCB when it's possible, feasible. And so you use rotablation, cutting balloon, and the DCB, and the result is good. And really, this is one of the examples that it can be done also in severely diseased and calcified lesion DCB. So just maybe, this was just a comment. I don't know what to add, but really a nice example.
About the IVAC, I was thinking about to do or not to do, because often I perform such kind of lesions without anything. But this patient had a 2nd and 3rd degrees AV block. As I said, it's because RCA and also that basohyaris chemical reaction. But I was afraid because there is a lot of calcification, and it was a heavy calcification, and a long part of the LAD was calcified. And I was afraid what will happen when I will pass with the burr. Will I lose just LAD, just the diagonal branch of both? So, I lost LAD, as you saw. So, and that moment when I lost LAD, in that moment I really need that IVAC, because I had a hemodynamically disturbance with that patient, and also I had again AV block of 3rd degrees, and his blood pressure dropped down. So I was really more comfortable with the IVAC. And as I said, it's not good as Impella is, but it's supported.
No, it's a really good example. I really liked this occlusion of LAD, and which is solved with the cutting balloon and the DCB. For me, this is the major point. Like a lot of tools in one artery, and with the final good result.
I had one explanation. So you stented the LAD, but you stented also where you did the mid-LAD.
No,
the stent, there was already a stent there?
No.
Because I see a long stent from left main to mid-LAD. So you stented up to the after the diagonal.
No, that was one stent. So that was a calcification. I put the stent from left main to the LAD. That was one stent.
Where? The mid-LAD or
no,
proximal?
The mid-LAD was calcified, so it looked like a stent. It's not a stent. And this bifurcation between diagonal branch and the LAD was treated with only with the DCB.
Only with DCB?
Yes.
Because at the end, the images, it looked like there was a stent also across the diagonal.
No, it's just one big stent.
See, you had low flow post rota. So issue was, would you have first taken a cutting balloon straight away? Because the calcium, though it looked adventitious, because it's an acute MI PCI, it's an inflammatory state. So we would not prefer to use the rota straight away. That's number one. Number two, the angle at the Remus and the LAD was very narrow. So whether you really want to put a stent there or you just put a kissing balloon for the circ, if you do a circ and Remus imaging, if you feel there is, just do a kissing balloon and DCB and just leave it alone. Because if you see your angle is, in narrow angles it is, especially in this setting, it is advisable not to put a second stent there.
No, this is the first stent from 2008. This is the first one. You know, he had acute MI 2008, and that was the first BMS stent at that time. So he had only that one stent before this procedure, and that was that stent of a rim, what you saw, and that was a BMS, and it was 2 millimeters from the ostial part of the rim. So this was in segment restenosis because this new restenosis also impact this ostial part. So I treated that only with DCB.
Okay, no, I think in the interest of time we'll move on. So thank you very much for that excellent presentation, the complex high-risk patient. Thank you. So
thank you.
The next speaker, good friend Yoshinobu Murasato from Japan, and he's going to present a case, stentless coronary intervention for left main and multi-vessel disease. Thank you.
Thank you, Chairperson. My topic is left main trifurcation region and multi-vessel CTO. The case is of a 51-year-old male was severe for angina. In his 30s, the patient battled the obesity, body weight more than 100 kilograms, and heavy smoking, 80 cigarettes per day. A decade prior to the presentation, he successfully quit the smoking and adopted a healthy lifestyle, including regular bike cycling 40 kilometers per day, resulting in a significant weight reduction to 75 kilograms. The patient experienced chest oppression and dyspnea during bike cycling over the past 6 months, promoting consultation at a local hospital. Coronary CT angiography revealed severe calcification and tight stenosis involving all 3 major coronary arteries. Given the complexity of the cases, the patient was referred to our hospital for further evaluation and optimal treatment. Despite comprehensive discussion regarding the risk associated with his condition and the potential limitation of coronary intervention, the patient emphatically declined CBG. His risk factor is dyslipidemia and ex-smoker. This is a baseline coronary angiography. Here you can see the left coronary artery, proximal LAD, and proximal LCX has a severe stenosis, tight stenosis. And distal left main also had a moderate region. Therefore, left main 1110 trifurcation region. And middle LAD has been totally occluded. And terminal LCX also totally occluded. This is a right coronary angiography. Here you can see distal RCA also totally occluded. Proximal part of the RCA also has a significant stenosis. And well-developed collateral from RV branch to LAD, and some collateral was found in the PD branch. Syntax score accounted for 46 points. Therefore, we persuade him to undertake the CBG. However, he declines the CBG. He eager to undergo the PCI. So we decided to treat the patient with PCI. First session, we planned the RCA CTO PCI. The coronary angiography revealed the microchannel in the CTO region. Fortunately, tapered wire XTR crossed the region, and we treat the RCA with the proximal part Zion's 3.5 by 48 stent, and the middle to distal part 3.0 by 48 drug editing stent. Some collateral was found from PD branch to septal branch. So we expected the development of the collateral, and 3 weeks later, we waiting for 3 weeks, and we tried to fix the LCS system. Firstly, we performed the LAD CTO PCI. Here you can see the simultaneous coronary angiogram from both RCA and LCA. Some microchannel can be found. So we approach with a Gladius slippery CT wire, and then change to the XTR wire, tapered wire. Fortunately, the guide wire progress into the distal side, and we treated with this CTO region with 2.5 by 48 millimeter stent distal LAD, and the middle part 3.5 by 34 millimeter stent. And then we move to the left main trifurcation region. Here you can see there is a tight region in the proximal LAD and LCX, and the region location is the contralateral side of both branch. So up to this procedure, we spent 4 stents for the 2 CTO PCI. So we decided to treat this region with stent-free strategy. So we use directional coronary atherectomy. Directional coronary atherectomy with a special catheter, atherocat catheter. This catheter has a window, and the window faces to the atheroma, and the contralateral side of the balloon inflated, and face to the atheroma, and put the catheter for the resection of the atheroma, and deflect the balloon, and rotate the catheter, and another direction we rejected the atheroma again. Rejected tissue stored in the nose cone. And we rejected the atheroma, firstly, left me to LAD, 30 cut. And then we remove the catheter and advance to the LCX, and we add the 20 cut for the LCX ostium. And then we treat this region with a drug-coated balloon with a agent 3.5 by 50 millimeter for LCX, and left main to LAD with an agent 4.0 to 20 millimeter drug-coated balloon. And this is the IVAS images. Before this, this is a pullback from the LAD to left main. Before the DCA, significant plaque was found in the proximal LAD and distal left main. After DCA, here you can see the significant plaque was rejected. And this is a pullback from the LCX to the left main. LCX ostium has also significant plaque. After DCA, this plaque has been rejected. Finally, the minimal lumen area is enlarged from the 7.3 millimeter square to the 10.4 millimeter square in the left main. In the LED, 3.8 to 7.3 millimeter square, and LCX 1.5 to 7.4 millimeter square, and the percent plaque area reduced to less than 60%. It is like the stent-like finding. This is the final CAG. Here you can see sufficient lumen gain was obtained in the left main trifurcation region, and the complete revascularization was achieved except for the terminal CX CTO, which relieves the anginal symptom. Ladies and gentlemen, this is my take-home messages. A physically active young male with complex LM trifurcation region with 3 vessel CTO regions underwent PCI, which had required 4 drug-edited stents for 2 CTO PCIs. In order to complex 2 stenting LM trifurcation region, sufficient plaque debarking with directional coronary atherectomy was followed by subsequent treatment with DCB. The application of the DCA plus DCB in the complex LM region reduced the potential risk of stent thrombosis in the elevated state of the coagulation associated with multiple stent placement. Thank you for your attention.
Thank you, Yoshi. Fantastic case, very complex disease and combination of stent and DCB. Given that the location of your DCB was left main bifurcation, are you concerned, given that prognostic territory, of a lack of scaffold leading to significant TLR and TLF beyond drug-coated balloons in smaller vessels and more distal vessels? Do you want to comment on in the absence of data, DCB in native vessels, prognostic vessels without a scaffold?
Especially such kind of topic problem, we use directional coronary atherectomy. So reduction of the plaque, that is very important. So we set the cutoff value for the DCB treatment. Percent plaque area less than 60%. That is the cutoff value for the treat DCB or treat or drug-edited stent. So reduction plaque to the less than 60%. So we can achieve. We treat this left main trifurcation region with a stent-free strategy.
Really excellent case. I congratulate you. I have one question regarding the use of atherectomy device, because I didn't have any chance to see it. And there are different sizes of this atherectomy device or not, and whether are you going to prepare the lesion after this atherectomy with some NC or cutting balloon before applying DCB balloon? How do you know whether if you don't use imaging, can you be sure that you did properly atherectomy?
And as you can see, as I presented it in the IVAS, the plaque burden is very severe. Especially LCX plaque burden is more than 80%. In such case, cutting balloon or squaring balloon is not effective. Especially in such case, severe dissection occurred. So we treat that region with coronary atherectomy. So coronary atherectomy does not cause such kind of serious dissection. So the pre-treatment with atherectomy is important, we think.
But after the atherectomy, do you perform NC predilatation again to prepare the lesion for DCB to deploy the drug? Because it's recommendation to do one-to-one predilatation with either NC balloon or like scoring cutting balloon before.
It is not necessary.
It's not necessary.
Because of the atherectomy, the inchma and the atheroma is rejected. So the drug infiltration is perfect.
Can I ask you, the left main was not critically diseased. It was ostial LAD and ostial circ.
Yeah.
because usually the indication for atherectomy is a focal ostial LAD, because if you put a stent, then you have the carina shift, and so this is the typical, and IVUS or OCT-guided, and said. But you decided to do both, and you check with the imaging, and then because the left main was not involved significantly, you decided to leave like this without stenting.
This side has involved more than 50%.
Yeah, but it was ostial LAD and ostial swell.
No. Yeah.
It's important to underline this, because if there is some maybe left main, it's better at least to stand from left main to the LAD.
Usually when there is ostial LAD, ostial circumflex, for sure it's like there is also distal left main disease, like in 80% probably, or even more, according to the IVUS studies. Probably that was your reason to do this procedure. I don't know. Thank you.
Compliments for the case, really fantastic, particularly for us from Europe, because I really, congratulations to leaving left main bifurcation after atherectomy, which is a good case, without stent audio. It's a really amazing case. I mean, you put 4 stents, 2 more stents, I think will change the future of this patient. Anyway, compliments, yeah. Great.
Yeah, especially for some doctors, the DK crash or some complex to stenting perform this complex left main trifurcation lesion. However, it will cause some thrombotic event in the left main.
Final question. When you do DCA on LAD, the wire in the circuit, you remove the wire from the circle, or you stay with the wire in the circle? You stay with the wire in the circle. The wire in the circle was not removed during DCA of the LAD, and opposite the same, because the wire are, you don't touch the wire with the DCA device.
When I perform the DCA, the only one, like a rotablator, the one guide wire to the LAD, and remove, and then advance to the LCX.
So there was the risk to occlude one of the 2 vessels because you removed the wire?
However, the resection of the atherectomy is completely, so it is not, it does not have the risk of the occlusion of the LAD.
Maybe allow one question from the audience. Just.
Fantastic case, wonderfully done, and the objective of having a good human preparation for the data which has come from South Korea now about using DB. Using DB in proximal LAD and larger vessels is not very encouraging as far as the DCB is concerned. So your comments, and particularly you're dealing with the left main with the bifurcation, and if the patient comes back with problems, it's going to be a difficult issue to tackle that. And this is coming, Jack, the latest one, last. Yes.
Also, is the risk of 2 stents in left main. There is also another risk. So.
However, reduction of the atheroma, plaque, plaque volume is very important. So the only DCA is a device for the atheroma plaque reduction.
So thank you very much for your. No, sorry, for the sake of time. I will introduce Mattia Lunardi with the topic: Is spot side pot enough? A keys to optimize. Let's hear.
Hello, everybody. Good afternoon. Thank you very much for your kind introduction. Well, this is a very illustrative case of the difference between these 2 ballooning techniques after provisional stenting. Well, we are talking about an 81-year-old gentleman, quite fit with few comorbidities, that was referred for CCTA because of effort chest pain, which revealed a distal left main significant stenosis involved with bifurcation, followed by a fibrocalcific diffuse disease of the LAD. Reason why he was referred to our cath lab. So this is the angiogram on the right system. You can see that the coronary is quite healthy, while on the left system we can appreciate the distal left main stenosis followed by a quite regular lesion of the proximal Mila LAD involving the bifurcation with the left main, but also the bifurcation with the diagonal. So the patient was referred to our heart team because we discuss usually all the patients having a left main disease or 3-vessel disease, and the discussion led to PCI. Since we are running a clinical trial in our center, that is the CRABIS trial, comparing the pot-side-pot versus the kissing pot technique, we decided to enroll the patient in this trial. And this is basically a technical study where the primary endpoint is the OCT assessment after the ballooning with either the pot-side-pot or the kissing balloon. So the patient, since we had to use the OCT for the trial, we decided to use that also for the pre-procedural planning. This is the first pullback before the PCI, where you can appreciate the distal left main stenosis and the long lesion at the proximal and middle AD, but also a patent ostium of the circumflex at the level of the bifurcation and a minimum lumen area at the middle AD of 2.2 millimeters square. So according to OCT, we got some measurement for our stent selection and balloon selection. As you can see, we got eccentric left main with the 4.2 by 3 millimeter, an indirect measurement of the ostium of the circumflex. This is very important to get, even if we don't pull back the OCT from the side branch. That was 2.70 millimeter, and a healthy reference distal diameter at the middle AD. It was more or less 3 millimeter. So we started our procedure with a provisional strategy. The trial provided for a provisional stenting of large bifurcation lesions, ballooning with a good predilation with NC balloons up to 3.5 millimeter at the middle AD and at the proximal LAD and left main, and then we place a first stent at the middle AD, 3.0 by 18 millimeter, followed by stent back to the left main, overlapped with the previous one across the circumflex and the D1 that was 3.5 by 34 millimeter. After that, of course, we proceeded with our POT with a 4.0 balloon. And then a very important step that I want to focus on a little bit, that is the distal rewiring, because either using the pot-side-pot or the kissing balloon, this is a very key step of the procedure to get, of course, the best achievable result. And you can check that both through the angiogram using markers such as the marker of the previous wire, the jail wire, or also imaging. In this case, the patient didn't have any problem with kidneys, so we decided to perform an additional OCT run during this step. And you can appreciate from the 3D reconstruction how nicely goes the wire into the last cell of the strut of the stent. So we were happy of this result, and we proceeded with the randomization that was pot-side-pot. Accordingly, we dilated the ostium of the circumflex with a 275 millimeter balloon according to the OCT measurement, the first OCT run, and then we did a repot, another POT with the same balloon of the initial pot. So the result was this one. That was actually not really satisfactory because we got some malposition that was significant at the level of the ostium and the proximal part of the LAD, up to 450 microns, and also a severe underexpansion of the stent that was 67%. In these cases, we can cross over to the other arm because, of course, this study, the primary endpoint of the study is image-based, but we want to get the best result for the patient. So we cross over to kissing balloon, and we performed a kissing balloon with a 3.5 NC and 2.75 millimeter NC balloons in the LAD and circumflex respectively, followed by another POT. This was the final angiographic result, but let's see the OCT. On the left, you can see the pullback that show a well-apposed stent all over the vessel, and the bifurcation showing a very patent ostium, and also in particular at the level of the proximal LAD where we got earlier huge malposition and significant under expansion, you can see now that the stent is well opposed, some minimal malapposition of a couple of strats, but nothing significant. So this is a very nice image that I would like to show you, because the 3D reconstruction, the fly-through mode of the OCT allows you to appreciate a lot the effort that you put in performing a good distal rewiring, because this is very important to avoid any metallic carina, and in case of a pot-side-pot technique, the shift of the metallic carina towards the mid, the lumen of the main vessel. So this is very important. Concluding, I can say that the PSP technique, the pot-side-pot technique, is a good technique, but we can have some, it is limited by some steps that don't allow to get a good position of the stent, in particular, of course, at the level of the distal main vessel, just after the bifurcation core, and some under expansion. That are two key factors of adverse events that you follow up. In this particular case, the kissing balloon was able to correct these imperfections, but also because of a good rewiring that was, of course, relevant for to get the result obtained. Thank you very much.
Mattia, excellent case, and I think it's a really important discussion, pot side pot versus the traditional kissing, and congratulations on the study. So the first question, imaging is mandatory with your protocol in this study?
Yes.
Yeah, with OCT?
With OCT, just one run after the performance of pot side pot or kissing, but we have the primary endpoint is based on imaging and OCT in particular.
Yep.
So we
I mean, there's a lot of discussion, despite the bench data, pot side pot versus kiss, and we also know from the clinical data with studies, routine kissing versus no routine kissing, there's just mixed results. It can favour routine kissing, it can actually favour keeping it simple. Often if routine kissing is adverse, the penalty is the main vessel. And I think one of the reasons is it's incredibly elegant what you show is using the imaging, particularly to know that you're rewiring in the correct cell, and also obviously not going abluminal. And Niels is not here, I think he's in the other session, but October showed there's the incidence of inadvertent deformation with bifurcation. So I think you've taught us two things, the pot side pot and then transitioning to a kiss, but also the value of imaging to know that we're in the correct cell, as well as the final result.
Yeah, of course, angiographically speaking, I don't think we can appreciate these differences, but OCT and in particular this study let us understand which is the differences in terms of geometry of the stents. In these cases, we don't know the clinical outcomes with what will be, but of course, doing it at the best, it's...
Do you, just a question, do you include just left main bifurcation patients or any bifurcation? Because
so
it can...
Large bifurcation, meaning left main bifurcation, or other bifurcation having at least a main vessel 3.5 millimeter diameter,
and
and side branch 2.75 millimeter.
2.75. Okay, because I wanted to just maybe to stress that it's not, it is different. There is a difference when you, in regarding the left main bifurcation and with pot side pot and any other bifurcation.
Yeah.
Because the side branch is usually smaller than the circumflex, usually, and then the deformation or the malposition probably is going to be smaller in other non-left main bifurcation lesions. So maybe this pot side pot, as you already mentioned, is not so applicable to left main bifurcation lesion. Either pot like crossover stenting and pot, or crossover stenting with pot kiss pot, because of the, as you already mentioned, because of the size of the side branch, which is usually more than 275. This is just my remark.
I completely agree. I think that if you perform a good rewiring even in the smaller vessels, this is true. But if you don't do that, you can have some troubles with the shift of the metallic arena, also in the smaller vessel, and it might be even more dangerous if the lumen is small.
Thank you. About the pod side pod, you used a semi-compliant balloon for the circumflex.
Yes.
You regularly use the semi-compliant, or you can use the NC balloon?
It depends on the case.
Because
in this case, we didn't see any disease, any calcium at the level the host of the circumflex, so we use that semi-compliant balloon just to open the cells and without forcing too much at the level of the bifurcation.
Yeah, we had this case that we did a few days ago. We did a kissing stenting, bifurcation and stenting with a semi-compliant balloon. And after the OCT, there was no good stent alignment on the side branch. So after using these two NC balloons of the side branch and the main branch, the stents was quite alignment was good, quite alignment good on the side. That was maybe the pot. If you do it with the, probably, I'm not using the pot side pot technique yet, but if you did it with this non-compliant, and maybe if you use it 4-0 on the left main LAD stent, you will finish with the pot side pot, I think.
Yeah, this is a good call. Thank you.
Thank you very much for presentation. Do you use imaging during the study in each case to confirm the distal strut passage, or just for malaposition?
No. It's mandatory at the end of the procedure in this study.
Okay.
But
just to fix distal malaposition or distal deformation
the result.
To decide to do kissing or not.
Yeah, then if the result is not satisfactory to the operator can decide to cross over to the other arm. Yeah.
So one question, Dr. Murasato. Yeah.
I would like to ask where the malabsorption side after the side branch dilation. Usually, side branch dilation is likely to occur the malabsorption is the opposite side of the side branch. Is that right?
Sorry, could you repeat?
When you perform the side branch dilation,
yep.
Malabsorption occurs the LAD. Where is the malabsorption side? Opposite side of the LCX?
I can show you maybe the. No.
Yes, it was the attraction because it was not corrected by the pot balloon because the balloon can't reach that malaposition at the ostium. This is the.
So when you use a long balloon, such kind of the malaposition is likely to occur because of the straightening of the ballooning causes the retraction of the strut to the direction to the left main. So the LAD ostium malabsorption is likely to occur at the opposite side of the LCX. So we recommend the short balloon for the side branch dilation or proximal balloon edge dilation for the pot side technique. So in Japan, we have already the study, randomized study, pot plus side branch dilation with short balloon and kissing balloon inflation. In this trial, that kind of the malabsorption is likely to occur less frequently. So I recommend if you use a pot side pot technique, use a short balloon or proximal balloon edge only dilation in the side branch ostium is better for the long balloon dilation from the left main to the LCX. Long protrusion in the left main is not recommended.
Thank you very much for your
the final comment. So one alternative to pot side pot is pot side main pot, okay, which is safer. And the other is the kissing because you don't know if you're angio-guided if you did the proximal cross. If you do a proximal cross, you have the neocarina in the middle. So in any way, you have this carina which is toward the main vessel or the side branch if you go with the pot to distal. So it's better, probably at the end of this discussion, to do pot, side, or kissing is better, and then pot, but perform proximal to the carina. So if you have a neocarina floating, it's in the middle.
Thank you.
Okay, in the interest of time, we'll move on. Thank you very much, Mattia. So the next presentation is Stepan Jirous, PCI of left main bifurcation in-stent restenosis with Bailout IVL and Impella support. Thank you.
Dear Chairman, thank you very much for the invitation to this event. The topic of my presentation will be the case with long name, but it will be short, don't worry. PCI of left main bifurcation in stent restenosis with bailout usage of IVL and Impella-CP support. My name is Stepan Jirous and I am from University Hospital in Pilsen in Czech Republic. Let's start with the clinical presentation. When he saw him for the first time, it was 84 years old man with arterial hypertension, diabetes, and chronic kidney disease. And he suffered acute MI without ST elevations sometimes in 2021 during the night. We are going to see the NGO in next slide, but there was provided PCI of proximal LAD and PCI of severely calcified 111 left main bifurcation with provisional stenting, only with one stent implantation, but with Impella support because of his acute heart failure. The result wasn't optimal, you are going to see, but it's necessary to say that in 2021, in our cath lab, we had no debulking method, including IVL. But the right coronary artery was quite okay. Here are the pictures from 2021, just the beginning of the case and the suboptimal result after provisional stenting with one stent leading from left main to LAD, but it was maximum what was possible during the night shift. The angiographical result wasn't perfect, but his clinical result was tested a few months later because he got severe COVID-19 disease and he was 2 months hospitalized in do not resuscitate regime in our infectious department, and you can see his CT, and he survived it. 2 years later, 2023, he got another myocardial infarction without ST elevation. The echo showed even worse systolic dysfunction with ejection fraction reduced to 20, severe pulmonary hypertension, and some mild mitral and tricuspid regurgitation. Here are the pictures. There is a severe calcified in-stent restenosis after provisional stenting in left main bifurcation and new lesions in proximal, middle, and distal right coronary artery. We have discussed it in our team, and we decided again to do PCI, and again with Impella-CP support. Because we had some time, he wasn't in acute heart failure at this time. We had time to do photon CT imaging of his femoral arteries, and we checked if it's still possible to insert Impella, and if there will be some ischemia of his leg after Impella implantation, if it will be necessary to let it there for a few days. Then we use ultrasound-guided transfemoral approach, administered Impella-CP without complication, and started with simple PCI of middle part of LAD with one drug-eluting stent, and then we moved to critical left main bifurcation. I have tried really long time, my colleague as well, but we weren't able to cross through the calcium and old stent to the circ. We tried different wires, and after long minutes, we have decided to do non-compliant predilatation from left main to LAD, but as a little bit expected, it resulted to occlusion of the circ. And this is the point of my presentation. We took as a bailout method IVL shockwave 4.0 from left main to LAD, and after usage of 50 pulses, suddenly disrupted calcium made possible the wire to cross to the circ, and it was surprisingly easy. Then we continued with PCI. We applied reverse tap technique, started with one stent implantation to the side branch, to the circ with minimal protrusion to left main, and then kissing non-compliant balloon dilatation. And then the stent in left main and LAD was implanted rewiring and another kissing non-compliant balloon dilatation. Here is the final result. Thanks to clear stent, it again isn't perfect, but it's better than in the first procedure. So, what's the message of my presentation? In case when the side branch is occluded and you have no wire in it, or you have a wire but you aren't able to get there during PCI of calcified bifurcation, you can try to use this bailout technique, which is well known from CTO cases described by El Basha 2 years ago. You can use shockwave inserted to the main branch, and it can allow you to cross the wire to the side branch thanks to disrupted calcium. Thank you.
Thank you very much. Yeah, very interesting case, complex restenosis. Any questions from or comments from the audience?
Just sharing what we would have done, we would probably have rotated in the beginning, might have created a little path. And sometimes the balloon doesn't go into the circumflex because the ostial circumflex also looked like it had significant calcium. You can put in another non-compliant balloon and then do the IVL to the bifurcation. Sometimes it loosens up the ostial circumflex a little bit.
Thank you.
Sorry, continue. Yeah.
Yeah, thank you very much for this point.
You did have a stent, though, going from left main into LAD from the original 2021 procedure, correct?
I wasn't the operator of the first procedure. It was my colleague during the night shift.
Yeah.
But
yeah. So would that influence you rotablating into the circumflex or not?
No, rotablated to the LAD.
Into the LAD, yeah,
so
yeah.
It would have made easier crossing.
Sorry, I
into
thought you
the
meant circumflex switch, yeah.
It would have made it easier to cross.
Yeah.
Yeah, I'm sorry, but in that year, we had no debulking method in our cath lab available. So.
I have also a comment. Sometimes when you add this stuff and you see this eccentric calcium at the roof of the left main is a nodule. It's a nodule. And nodule is very difficult to treat. Even with the rotablator, yeah. It's not directional orbital atherectomy. It's not perfect, but there are some case report of using the IVL in calcify. You can crack these, and then you allows to. So one strategy in this case could be a rotablator at the beginning, just to create some space, IVUS or imaging anyway to see and try to go in the circ, and then go directly to IVL without trying to open it. So prepare with the. If there is a nodule calcium, probably IVL is the only way because it's bigger than a small rotablator burr, bigger than an orbital atherectomy, and can crack something, and then go with the procedure, predilation, etc., etc.
I have one question regarding the second procedure, and you said that you put 2 stents in the second procedure, like inverted tap, as I understood. Because there was already one stent, crossover stenting from left main to LAD. Yeah. And you didn't decide to go just to proceed with TAP to put additional stent, just one stent, and to finish like. So now there are 3 layers of stent in left main. Do you?
It was like a nano crash. You didn't protrude too much the stent in the circ. You did so it re-entered in the true lumen of the stent. In the
from the first
the difference with the classical crash that you re-enter in the circuit through the side branch of the stent, the side strut of the stent. But in this case, you protrude because the angle was favorable. You put the stent just exactly like a T, and.
Yes, but he put additional stent. That's why I was like thinking if there is already one stent for left main LAD.
2 layers, only 2, because in the circuit it was not crashed.
Yeah, but there was just one stent, and you put 2 additional stents, yes?
Yeah.
Like left main LAD, so there are 2 layers in left main.
Yes.
And
yes, but this is like a stenosis.
Yeah,
normal stenosis.
There are 2 layers in left main and LAD, proximal part of LAD or ostium of LAD, but the result just after balloon was terrible.
Okay, that's why, because sometimes you can finish with just additional one stent to convert to like to TAP, TAP or to culotte or to like. in such a cases. But okay, you said the result wasn't satisfactory, and that's why you put an additional stent. Okay, yeah. I understand. Thanks.
Yeah, but even because as you said, this eccentric calcificate burden.
And it was a nodule, so you have to do something.
So the extra stent actually gives bigger support. Yes.
Yeah, yeah. But particularly compliments for the case because you have one stent from 3 years ago, calcified, restenosis, the patient is at 20% fractional ejection fraction. You do the procedure, obviously put 2 stents, don't care about that, whether you have 3 layers or 2 layers, and mostly you use the lithotripsy, and you don't know what is the situation with the first stent, so it's better to cover it and don't think about 2 layers or 3 layers. It's a perfect procedure. Yeah. Compliments.
I think the same, and another point is that he was 86 years in the second procedure, so we decided this way.
Another key point is to use imaging in these cases.
Yeah, yeah.
This is really the case that we have to apply imaging technique before we decide what to do.
To be absolutely honest,
especially that you have Impella-CP support in this case, so it's like
it was second very expensive case for our quite small cut lab. We used 2 Impellas, we used shockwave in quite old man, and to take another expensive method like OCT, we considered it. And then we decided not to use it, and it was one of the reasons. The second was his chronic kidney disease, and we tried to make it with low contrast as possible.
Excellent. Well, thank you very much. Excellent case. Really appreciated you presenting it in the discussion. So we'll move on to the final presentation.
We have the last case, which is by Giuseppe Marchese from Italy. It's an OCT-guided calcific distal left main PCI after ostial circ CTO recanalization and IVL mediated lesion preparation.
So good afternoon. This is the first time for me at this very special meeting, so I'm very pleasant and honored, and we will move on to my cases. I'm Giuseppe Marchese from Italy, and I did this case with my head, that is Gianluca Rigatelli, that maybe someone of you knows. So it's a 60-year-old gentleman with a recent history of inferior ST elevation MI, treated with primary PCI and single stenting to the right coronary artery. The left system presented with distal left main critical stenosis, LCX total occlusion, and distal descending artery diffuse disease, apart from a critical stenosis of the first diagonal that I didn't cite it here. With a quite standard therapy, especially about the depth with the prasugrel, and with an echocardiography with moderate LV dysfunction, with infraposterolateral akinesia, and for the rest a normal exam. And we calculate the Sinta score. It was 34. As per guidelines, we want to discuss this case with the cardio surgeon, but the patient categorically refused any surgical option, so we planned and we aim to the complete percutaneous revascularization. I skipped the angio of the RCA. We focus on the left system that present, as just said, the critical stenosis of the left main, but especially a signal of minus of the distal left main with the occlusion of the circumflex. So we stabilized the distal LAD very quickly, just to have a runoff with the DCB, paclitaxel DCB, with the acceptable results, not a big vessel. And then we approach the ostial CX CTO. There was a bad angle, so we decided for a supercross 90-degree angulated microcatheter, and we started their anterograde wire escalation, starting with Fielder XTA, that, as you can see, maybe has a good direction and maybe is intraplaque. Then we pass over with the Gaia second with no big progression, and then with the Conquest Pro 12, we progress a little bit, but clearly in the subintimal space. So we went back. As you can see from this last video, the support is really bad, not really a good support. So we decided to upgrade the microcatheter passing on Corsair Pro XS and de-escalate to Gaia second wire. And with this strategy, we were able to reach the distal true lumen. This is the imaging angio feeling, but it was a good feeling also from the tactile. So at this point, we have a technical complication. We have something like a fusion between the wire and the microcatheter. So this entrapment was impossible for us to keep out one of the two devices. So we need to take both like a unit out from the patient. So we were in this situation after the wire microcatheter removal. Even if it is small, you can see that there is some anterograde filling of the circumflex artery. So we decided to go with the Gaia third free wire, and we were successful in this. And we started to dilate with low entry profile 1.0, 2.0 with some expansion. But when we perform the first kissing balloon, we were not satisfied with the balloon shape in the point of the distal left main where before you just saw the signal of minus at the angiography and something like a radiolucent mass. So this was the angio after this preparation of the CTO. So at this point we decided that we need to crack something, and we opted for the IVL treatment with a 2.5 shockwave balloon. We always do the dilatation, but we deliver the impulses in different position just to have different angles of delivering the energy and the shock waves to the plaques. And this is exactly what we did, and especially we were able to put the balloon more distal, and then this was a signal of efficacy of the treatment. Apart from that, there is not image of this, but after this treatment, we always do a dilatation with a non-compliant balloon. In this case was a 2.5 non-compliant at high pressure, 18 or 20. And then we decided to stent this left main. We opt for a dual stenting technique. So we, as I told you before, I work with Gianluca Rigatelli. So we perform the technique that is invented from him and studied. So the non-inverted stenting that start with the ostial cheek stenting. We use a thin strut stent like Corsair, and the key point of the technique is the accurate ostial cheeks placement of the stent with the distal ring of the stent protruding in the left main, more or less one strut, less than 1 millimeter if it is possible. So then after the placement of the stent, we crush it with a non-compliant 3.5 in the left main LAD at high pressure, and then it was quite easy to put a stent in the left main LAD 3.5-23. Then we pot it with a non-compliant 4.5 per Finet law at 18 atmosphere initially. Then the cheeks rewiring also in the distal cell, and the kissing balloon with the non-compliant 3.5 in the LAD and with the 2.5 in the circumflex. So this is the angio result, quite satisfactory for us. And as you can see from the third video, we also perform OCT to check the expansion. I have only the still frames because we were quite satisfied with the expansion and the sizing of the stent in the body of the left main. There was some mild malapposition, but the other detail is the still frame of the CX ostium that is quite good, but as you can see, there is some protruding calcific mass in the ostium of the circumflex. But we decided to finalize the procedure with the last optimization with the same balloon, so we didn't upgrade the size, we upgrade only the atmosphere, we went to 22, and then this is the final result, just angio. We had some follow-up, some clinical follow-up, because we planned stress echography at 6 months. That was negative for ischemia. At 10 months, the patient is free from angina and non-cardiovascular events occurred. So my conclusion are that when it's technically feasible and with good risk-benefit ratio, the indication has to be always to complete revascularization if possible. Here we use a CTO technique that is called scratch and go, and is a good way to modify the proximal cap of tough CTO like this. In this case was effective. Contemporary data and the latest CCS guidelines highlight the need to use intracoronary imaging, especially in treating a subset like the left main. Intravascular lithotripsy in this case and in a lot of other cases for us is very user-friendly debulking technique. And here you have a practical demonstration of the NIT, the non-inverted T, as an effective and rapid technique. So that's it. Thank you for your attention.
Excellent case. Just a question. You obviously showed the post-imaging. Did you imaging at any stage pre-stent implantation, the circumflex, to help decide using IVL maybe versus rota? And did you image pre-stent in the left main LAD?
No, we just did the final imaging because we practical thought that we didn't have so many other options apart from IVL, because we don't believe in this subset, in this kind of focal lesion, especially. I'm not an expert of OCT, but this sounds like a calcific nodule protruding into at least the circumflex, and we don't believe that the rotablator is the way to treat this kind of lesion. And we didn't have orbital atherectomy in that. So we were practical, we cracked the much possible. We had good result with the non-compliant at 2.5 at atmosphere, and the circumflex was not so big. So this is what we can reach with our tools.
Sure. Thank you.
Thank you for excellent case presentation. You had a very good result in left circumflex after pre-dilatation without any obvious big dissection. Didn't you consider provisional approach or maybe just DCB in left circumflex? As you said, it was not very big vessel. And
yes. We strongly believe in DCB. As you see, we use it also even if it is in a small distal vessel, so the whole indication. We always think about it, but in this case, I invite you to take a look on the first image. There was a ostial CTO with a calcific minus, with a radiolucent image, angiographic image. So we didn't believe that the balloon was enough after so much work.
A question from the floor. Yeah.
Yeah, it's more comment. You know, you can't argue with success, and you had a good result. So congratulations on that. My only concern was, you know, you were dealing with a CTO, and unless it didn't project well on the pictures, you didn't really know where you were going, because you know you didn't do a dual injection to see the retrograde filling.
Yeah,
and
you're
I
right.
understand you say that you know it felt good, but you know I do a lot of CTOs, and a Pro 12 and a Gaia 3 will go anywhere, and it feels good wherever it goes because it's like a needle. It cuts through anything. So my only criticism is you got a good result, but I think we can't take shortcuts when we're doing cases. You have to do the retrograde injection. You have to know where you're going, because it ended up well, but it could have been a disaster as well. You have to see where you're going.
Thank you very much for your comment. You're absolutely right, and we are methodical in respect the hybrid CTO approach. But in this case, I didn't show you, there was really a poor collateralization from the right, so that's why we didn't take another catheter. That was very easy. It could be a 5 diagnostic, but it was not useful. The things we learned from our CTO ITER was that it's very important also the feeling, tactile and angiographically, what you see, how is moving the guide wire. Of course, I didn't report this image or this angio video, but always then nobody is calm and quiet in working with the guy at third. So we, of course, exchange the wire, we perform a small injection, and this was done, so we were safely fine that we were in the true lumen distally.
Thank you very much for your presentation. And yes, we can close this session. And I want to summarize a little. So we have the first case we have 5 cases. And the summary is that DCA is useful sometimes when you want to reduce the stent that you want to implant, especially in very complex patients. In Japanese country, there is this DCA device which is not available in Europe that can be useful in very eccentric LED ostial or circ, and can be followed by drug-coating balloon because this is the tip and tricks, or stenting if the result is not optimal. The weakness of POTS-iPOT has been shown in the case by Mattia Lunardi, and this is, in my opinion, a reason waiting for the result of the stent to use a kissing balloon instead of POTS-iPOT as suggested in the past. IVL is another option that we have, and IVL can favor opening of occluded vessel, crack the ostial occlusion, calcified occlusion, and help to also we have 2 cases of nodule, crack some calcified nodule, and allows it's not good, expansion. From imaging, that is useful, you can see that this nodule protrudes inside the vessel, and there are cases reported TCT, etc., of regrowth of this nodule inside the stent. So what I suggest is to follow up the patient, especially with the nodule in the distal left main, a 6-month follow-up, because there is not a low percentage of restenosis and a nodule growing inside inside the stent. That's all. I think that we have some tips and tricks from this, and do you have other comments? So thank you for your attention, and we leave the room for another session.